Thanks again, everybody, for joining today. I'm really excited to be talking to you all about harnessing data for impact in EHE and breaking down systems change to more effectively monitor and evaluate EHE. Just a reminder, if you just joined, please mute yourself to sort of limit interruptions throughout this presentation. But other than that, I am Brittany. I'm the Senior Manager of Monitoring, Evaluation, and Learning at NASDAD. I'll be presenting here today alongside Kaniqua, who is our Data Integration Manager on the Health Systems Integration team. And we are excited to be presenting today. You can go ahead to the next slide.
All right, so welcome again, everyone. As Brittany mentioned, my name is Kaniqua Outlaw, and I am the Data Integration Manager with NASDAQ's Health Systems Integration team. And if you have been around with EHE for a while, you may have seen me at some of the intensive technical assistance meetings, actually all of them. I've been to all of them, except for one of the later ones. So if you're not already aware, NASDAQ serves as the EHE systems coordination provider, and we support 47 Ryan White HIV/AIDS program parts A and B jurisdictions that are funded by HRSA to implement the EHE, or Ending the HIV Epidemic initiative. And so with that said, we've actually had the pleasure of working with over 34 jurisdictions to examine from a systems level perspective any opportunities that can be used to support linkage, retention, and re-engagement of people with HIV into care and treatment. And so the really unique thing about EHE is that it allows us to take a broader approach to addressing HIV beyond what you already may be familiar with or what you may have already done through and under Ryan White. And so, like I said before, if you've attended any of the intensive technical assistance meetings, then you know that we really hone in and focus on the innovation and creativity in integrating efforts and engaging care delivery systems and sharing best practices. And you'll hear that name, that phrase systems used quite a lot, because what our goal is here is to engage and approach this from a systems perspective. Although we are dealing with individual people, and every individual person is one more person that we can engage and hopefully utilize that to reach that goal for EHE of reducing new infections, we do that work through a systems level approach. And so what we're looking at throughout EHE, throughout this conversation today, is how can we identify innovative strategies to reach those folks who have been linked to care, retained in care, people who need to be re-engaged into care and treatment, utilizing systems thinking. And Brittany will talk quite a bit about that today. And we just ask that you think about this in as broad terms as you can with any of the work that you're doing going forward, and utilizing what you learn here today as you develop or improve your EHE program planning and evaluation. Next slide, please. Okay. So the overall series, Harnessing Data for Impact, there are 3 parts that we've designed for you. Today's focus will be on reviewing systems and systems change and introducing a multi-level evaluation approach for EHE. The second session that we will have 2 weeks from now will be on how we then take that systems level thinking and incorporate that into learning how we can identify and create systems-oriented data collection methods and utilizing or identifying those tools to help you be able to make decisions, learn from what you're doing within your EHE processes, and potentially that outreach and impact for those folks that you're looking to engage. And then the final webinar in the series is still TBD, which means that you get to really be able to tell us what you hope to use that last session for. So right now, we're considering using that final session as a sort of office hours or to troubleshoot any of the materials that we kind of go over today and in the next session. So we really want to make sure that that session is driven by your input. Hence why we're focused on an evaluation, because the information that you glean from evaluation and that feedback can help you to enhance and improve your EHE programs. So with that said, this webinar will be recorded and available after today, and we'll also provide the downloads to all the slides after this session. So with that being said, and without further ado, I will hand it over to Brittany.
Thanks, Kaniqua. As Kaniqua mentioned, today we'll be exploring systems in the context of EHE and the HIV care continuum, but we'll also take it a step further by understanding systems for evaluation planning in EHE. We'll then talk about multi-level evaluation, and I'll be introducing a multi-level evaluation approach that has been developed by NASDAD. Next slide, please. So in addition to the objectives, I wanted to do some level setting on what you can expect and not expect from this webinar today. So the first is systems change and evaluating systems is an emergent field. There's so much new information coming out on an ongoing basis. So this is just to say that I don't know everything and I may not be able to answer all your questions because I'm still learning just like all of you, but I will definitely try my very best. And next is that this isn't an exhaustive course in evaluating systems, nor will we be spending time learning basic components of monitoring and evaluation. There's really so much more we could go into in these topics, but I wanted to cover the very basics to get us on the same page of thinking and then bring the focus in on EHE. So I have included my sources in this presentation, and I'm happy to share other resources for learning on these topics with those who are interested. My contact information will be available at the end, and you can personally reach out to me if you have any follow-up questions on anything we talk about today. And additionally, local context is very important when we're talking about monitoring and evaluation. So if you're feeling like maybe some parts aren't totally applicable to your jurisdiction or EHE, like that's okay. This really is not a one-size-fits-all approach. It's really meant to provide you with some guidelines and ideas for reframing your thinking on how you monitor and evaluate your progress in your EHE initiatives. And although we will not be learning about procrastinating and rationalizing like Calvin is in the comic on the left, I do hope that you will learn some real skills you can apply in your work today. Great. So systems and systems change in the context of EHE. In this section, I will be reviewing basic components of systems thinking, and systems change. And you might find yourself asking like, okay, what does this have to do with EHE or my work in particular? And I encourage you, as we're talking about systems and the different elements of systems, how EHE and the HIV care continuum in general fits into these concepts, and how thinking about EHE as a system can help you find ways to more effectively monitor and evaluate your EHE strategies. So I love a good definition, and I'll be walking through a few with you all today. And there's no shortage of definitions of systems out there. If you type it into Google, you'll get 1,000 different definitions and results. And as one prominent researcher on the topic of evaluating systems change said, those interested in learning more about systems may encounter a bewildering array of competing definitions, theories, frameworks, and methods. And it is very true. There's many different frameworks. There's so many theories around systems in different contexts. So for our sake, I want to find a way to define EHE systems, which for me refers to the interconnected components, processes, and networks that collectively work to support the 4 pillars of EHE: diagnose, treat, prevent, and respond. These systems are designed to work together to achieve the overarching goal of reducing new HIV infections in the United States by 90% by 2030. In other words, systems of EHE include the people, technology, organizations, government entities, funding mechanisms that are all working together to achieve the ambitious goals of EHE. Because we know that EHE doesn't work alone, and systems are not isolated. They're designed to interact and reinforce one another, and that's what creates this coordinated approach to combating the HIV epidemic. But even focusing on just one definition, we might still have challenges of conceptualization because these systems are so large, so multifaceted, and can be really messy. So, the question for us as evaluators of this system is, how can we impose order on this complexity? What conceptual categories can help us know where to look when we want to analyze how the system works, or what the facilitators and barriers are to changing that system? So to help us answer that question, it's important to characterize what makes a system a system. Next slide, please. So what makes a system a system? A system is defined by several key characteristics that really distinguish it from just a mere collection of activities or entities. And the first concept that is really probably the most important is the interconnectedness and interdependence, which refers to the various components working together towards a common goal, as well as the notion that the functioning of each component affects and is affected by others. So, for example, the effectiveness of a healthcare delivery system depends on public health infrastructure, data systems, and community engagement efforts. This interdependence means that changes in one part of the system can have ripple effects across the entire system. A system should also operate with a common purpose, whose components are oriented towards achieving specific shared objectives. In EHE, the overarching goal is to reduce new HIV infections, and each component of the system, whether that's a clinic providing ART, a community organization promoting PrEP, a policy framework ensuring equitable access to care, they're all contributing to this common purpose. Additionally, a system has boundaries that distinguish it from its environment or from other systems or subsystems, which are systems within systems. And these boundaries define what is inside the system, what's outside, even though this system may interact with its environment across these boundaries. A system also has a defined structure. So these are where different components have specific roles and responsibilities and have established processes and protocols that guide tasks, how tasks are carried out, and how the different components in the system are interacting with each other. Furthermore, the complexity of a system comes from those interactions and the fact that the behavior of the system cannot always be predicted simply by understanding the individual components of a system. And finally, systems should be adaptive to the environment by incorporating new technologies, research findings, and best practices. So this adaptability ensures that the system remains effective in rapidly changing environments. So an EHE system should be responsive to emerging trends in the HIV epidemic, such as changes in transmission, advances in treatment, or even shifts in public policy. So now that we know what a system is, I want to pause for a second and see if we see EHE as its own system, what would you all say are some of the key components of that system? You can go ahead and enter into the chat if you can think of any. Again, these would be the key players that are working in tandem to achieve EHE goals. This can be organizations, this can be other public health programs, the government entities we work with, technology or data systems, funding mechanisms, but what are the specifics of these in EHE? Medicaid and pharmacists, I'm seeing in the chat from Rebecca, definitely. Community-based organizations and medical providers, definitely. Prevention programs, and that I think that can, that can be at the health department level, that could be in the community-based organization level as well. Ryan White program, yep. Federally qualified health centers, harm reduction. Yeah, these are great. Thank you. Feel free to keep putting some ideas in the chat. Top One Housing are definitely state and local funders. And we can go to the next slide, Zoe. So if we see EHE as a system, then there are also subsystems within EHE, which include some of the responses to the question on my previous slide. And I think actually all of them that people have put into the chat are pretty much showing up here in some way or the other. So we see payer systems. So this includes the various funding sources and insurance programs that cover the cost of HIV-related services, treatment, and prevention efforts. So someone mentioned Medicaid, but also includes private insurance, ADAP, patient assistance programs. We also have healthcare delivery systems, which refers to the network of healthcare providers, clinics, and hospitals that offer HIV testing, treatment, and prevention services. So someone had mentioned federally qualified health centers, and that also includes other hospitals or community health centers and pharmacies, someone also mentioned. Policy and governance systems are the frameworks, regulation, and funding mechanisms that guide and sustain HIV testing, treatment, and prevention efforts. We also have data and information systems, the technologies, which are the technologies and processes used to collect, manage, and analyze data on HIV, incident, treatment outcomes, and service delivery. And then finally, we have community-based and social support systems. So these are organizations and support networks that engage the communities to provide education, reduce stigma, offer harm reduction services, and connect individuals to care and social support. And this also includes some of what folks had mentioned, like housing. So it's the networks that provide mental health services, the housing assistance, peer support, and basically any other essential service that helps individuals maintain their health and help them adhere to HIV care and prevention. So this isn't an exhaustive list. And in fact, there might be additional components or systems that are unique to your jurisdiction, but it's a starting point of a way I just want to show of the different players that contribute to the EHE system. You can go to the next slide, please. So, but across the board with all of these different players, there should be a concerted effort to ensure that these systems are working in tandem. So ideally, there should be collaboration across systems, which is, all the different players, the healthcare providers, the public health agencies, the community organizations, all working closely to ensure that services are delivered efficiently and reach those most in need. So, for example, a newly diagnosed person with HIV might be immediately linked to care through a community-based organization, with their treatment and follow-up coordinated across different healthcare providers, all using a shared data system. Next, there should be intentional integration of services. So systems are designed to integrate services at multiple levels. So for instance, HIV prevention, like PrEP, is offered alongside other sexual health services. Mental health support is provided in conjunction with HIV care, or public health campaigns that are tailored to address the unique needs of specific communities. And lastly, adaptability and responsiveness. So the systems within EHE should be built to be adaptable, allowing for rapid response to emerging trends or outbreaks. For example, if data systems detect a rise in HIV cases in a particular area, the public health and community-based systems can quickly mobilize resources to address that outbreak. Next slide, please. Now that we know what a system is, I want to define a term that we see in this work often. Systems thinking is a perspective that emphasizes the patterns of interrelationships between parts in the whole rather than the parts in isolation. In other words, it's the ability to see how we organize systems, subsystems, and their parts interact and influence each other. So how these systems create and contribute to specific problems. And systems thinking is important in EHE to navigate the complexity of our health systems to better understand the system-wide effects, whether those are positive or negative, planned or unintended consequences of EHE, and again, just allows for a more adaptive implementation as well. And it's important to mention that really from a systems thinking lens, there's nothing that is not somehow part of a system or a system in and of itself. And the world is complex, so systems thinking helps us see it as an interconnected set of systems. Next slide, please. So systems change in EHE is the intentional, comprehensive, and sustained transformation of the various systems involved in HIV care and prevention to better achieve the initiative's goals. It involves altering the structures, processes, and relationships within and between those systems to enhance their effectiveness, efficiency, equity, and responsiveness to the evolving landscape of the HIV epidemic. Systems change within the EHE initiative is about fundamentally rethinking and restructuring how HIV prevention, care, and treatment services are delivered and supported. It's about moving from the incremental improvements to transformative changes that can really help us accelerate progress towards ending the HIV epidemic. So by focusing on systems change, EHE aims to build a stronger, more responsive, and sustainable infrastructure for addressing EHE. The primary goals of system change within EHE is to create that more effective, equitable, and sustainable response to HIV. But more specifically, systems change is aiming to eliminate obstacles that prevent people from accessing HIV prevention, testing, and treatment services. And this includes addressing social determinants of health, such as poverty, stigma, and discrimination that disproportionately affect marginalized communities. Additionally, by transforming the systems involved in HIV care, the goal is to achieve better health outcomes for people living with HIV, including higher rates of viral suppression and lower rates of HIV transmission. Systems change also seeks to make the response to HIV more efficient by streamlining processes, reducing duplication of efforts, and ensuring that resources are allocated where they can have the greatest impact. And lastly, building systems that are adaptable and resilient, capable of responding to emerging challenges, such as new HIV outbreaks and changes in the healthcare landscape, is another key goal of systems change in EHE. So in case it wasn't clear, most of you, I think, are already doing systems change. One example of systems change is the broadening of access to PrEP. So through new policies or training healthcare providers and partnerships with community organizations to reach your priority populations, or implementing rapid start programs where individuals diagnosed with HIV begin ART as soon as possible is another systems change, because this approach requires changes in clinical practice, patient education, and care coordination. Another example is advocating for and enacting changes to laws that criminalize HIV transmission or non-disclosure based on current scientific understanding of HIV. So that's an example of policy-driven systems change. And then finally, expanding telehealth services for HIV care and prevention, especially in response to the COVID-19 pandemic, is an example of how systems change to adapt to meet the needs of patients while maintaining continuity of care. Okay, so now that we all know about systems, what that means for EHE, I think we're ready to dive in a little bit of how that affects how we evaluate EHE. So let's talk about some differences between evaluating simple programs or interventions and more complex interventions or systems like EHE. So for many of us, we're used to thinking about program evaluation for simple interventions. We follow the logic model or the plan by beginning with our inputs, including staffing or funding. We then conduct activities relating to our overarching intervention or strategy. We then expect some sort of outputs or evidence that something is happening. And then we report on outcomes, usually short-term outcomes. And if we're lucky, we can report on some long-term outcome or impact. And this model comes with an assumption of linearity. So that's to say, we do one thing, then this other thing will happen. We complete step one, we go to step two. So we now know that individual interventions like this are not really the ones that are going to be making those transformational changes, at least not on its own. And the reality of most initiatives, especially one like EHE, is more like on the right. And so you can just click a bunch of times. And it's something that is not as predictable and linear as it is with simple interventions. As we've heard, one thing in a system influences another thing. There are unintended consequences in addition to the intended effects. Things happen out of order or simultaneously, and some things take longer or shorter than anticipated. So these dynamic interactions are what set systems apart from solitary interventions, and such dynamics are what justify a different approach to evaluation. So if we see EHE as a whole were to follow that more linear path of that simple intervention, this is maybe what it could look like for EHE strategies. And I wanted to put it in this way because I wanted to find a way to really simplify systems change in the context of EHE, because systems are complex and rich, and evaluating them can often feel abstract. So in an ideal world, we'd be identifying that problem, we'd be implementing our EHE plan, we make changes on structural, system, or community levels. That change is implemented and sustained, and then eventually we'd see some sort of client level impact. And since system changes are meant to provide more positive outcomes for clients, and since system improvements can be difficult to measure, sometimes evaluators sort of use this proof in the pudding approach, that if outcomes are better for clients, then system improvements are assumed to have taken place. However, we know that there are many reasons why client level outcomes may not end up meeting goals or expectations, and these are just to name a few. You can go ahead and click, Zoe. Thank you. You can go ahead and click the next couple times. Perfect. So these are just a few examples of why our EHE plan may not go perfectly. Delays due to local laws and policies, competing priorities, funding challenges, understaffing, stigma, and the list could go on and on. But you also might end up meeting goals, but have trouble explaining how that happened or what change you made that resulted in the outcome you wanted. So when evaluation is only taking into consideration that client level impact and not all the other steps that led to that impact, it's not just not telling the whole story, but it's also a disservice to all the work you've done to change systems and make improvements in your jurisdiction. And I would actually argue that evaluation is a lot more than client level impact. And we should really be operationalizing and assessing system level improvements, which often appear before change manifests at the level of the client or the individual. Additionally, while better impacts for the individual should remain the ultimate goal, and the EHE initiative should be clear about how they're contributing to that goal, other outcomes related to the systems initiative or strategy are important measures of progress along the way, such as process measures or short-term outcome measures. When we're creating systems to help us track progress that is not just connected to client level impact, we end up creating these robust monitoring systems that help you not only better tell the story of your work and the steps you're taking to work towards your bottom line client level outcomes, but it can also help track unintended or unexpected effects that often happen in systems level work. And as we've discussed, the complexity of EHE requires us to be innovative in our approach to evaluation. So systems thinking really helps us in this design. And finally, we want to be sure that when we're evaluating our EHE initiative, we're taking into consideration all the elements of the system, being realistic with what is achievable within our jurisdictions, and finding opportunities for evaluation that is not just the client level outcomes. Because when system conditions and dynamics aren't considered in the evaluation's design, the evaluation will inevitably miss crucial aspects of the intervention and its environment that are affecting the intervention's operation and success. So with that being said, I'm going to introduce an approach that might be helpful when thinking about how to go about breaking down your EHE strategies and activities into a feasible monitoring and evaluation tool using systems thinking. So what is multi-level evaluation? I had promised definitions today, and I am definitely delivering on that. Multi-level evaluation is an assessment process that involves analyzing and assessing a subject, process, or system at different levels or stages. This method is often used to gain a comprehensive understanding by breaking down the evaluation into distinct levels, each focusing on specific aspects or criteria. So in other words, we want to try and break down our EHE strategies and interventions into different levels of where we anticipate seeing an impact. So why use multi-level evaluation for EHE? So firstly, it allows us to break down our EHE initiative into levels where we see potential for impact and therefore an opportunity for evaluation. Additionally, it allows us to think more broadly about our strategies and interventions and potential for other impacts. And finally, the complexity of EHG lends itself to a multi-level approach to help us to make it more manageable for us to monitor and evaluate. So this is a multi-level evaluation framework for EHE. So let's break this down a little bit. I'm going to start on the right side where I think most folks are familiar with the 4 EHE pillars. So the 4 EHE pillars are what informs your strategies and interventions on the left, but it is also what you are aiming to accomplish with your strategies and interventions. So we've broken down the strategies and interventions into levels of evaluation or where we see opportunities to measure impact. All EHE goals are tied to client level health outcomes, but the strategies that are being implemented to achieve those goals also have effects on other aspects of the system that could lend itself to evaluation, which we've broken down into these 4 levels: jurisdiction, jurisdiction staff, subrecipient, and client or priority population. So depending on your strategy, you may or may not be evaluating at every level for every single strategy that you're doing with EHE. But you should be thinking about, for each strategy, process, short-term, and then intermediate or long-term measures for your strategies and interventions. And some other things to consider here too are just what is feasible to measure. We're not going to be able to track and measure everything. So really thinking through what is the capacity of you or your team. And then also something to think about is how can you measure not just success, which I think most of us are using our long-term outcome measures as sort of our measure of success, but also progress. How can you track the incremental changes that you're making to the system that are showing that you're taking the steps that will hopefully lead to those longer term outcomes? So after our next webinar, NASDAD will be hopefully releasing EHE evaluation planning tools sort of based off the framework I just reviewed. And this document will hopefully help guide some of the thinking that we've talked about today and help you apply those concepts to your jurisdiction. So I'm going to take a few moments and review some of the key elements in this tool and then run through an example of how you might use it. And just a caveat that this really isn't meant to replace your monitoring and evaluation plan, but something that I hope you can incorporate or adapt to improve your monitoring and evaluation processes. So these levels of evaluation that I've been talking about, or opportunities to measure impact, were created based off what the goals of EHE are and where many jurisdictions are focusing their interventions. So the jurisdiction level represents the agency of the jurisdiction. So this could be the state health department. This could be just the HIV, STD, and viral hepatitis department, if that's how you define it. If you're a city or county, this could be the city or county health department. But really, this level should evaluate the systems of the agency that is facilitating the implementation of a process, strategy, or intervention in EHE. And this level also helps us assess the agency's overall outcomes at the systems level experienced by the organization. Next is jurisdiction staff, which could be an EHE manager, coordinator, the entire team, helps us evaluate the knowledge, learning, attitudes, or skills of jurisdiction staff to actually implement EHE strategies. We then have subrecipient, which again, depending on your strategies, could be community-based organizations, providers or clinics. If you're a state health department, a city or county health department could be a subrecipient of your EHE activities. And this level evaluates the implementation of EHE strategies by the subrecipient. And priority population is the target population of strategies and initiatives and evaluates any outcomes for clients that may happen due to EHE interventions or strategies. So those are typically sort of your longer term outcomes. And as I've mentioned, this framework is meant to adjust to your needs. So if there are other levels not identified in this framework that are unique to your jurisdiction or work plan and distinct from the other levels, you can definitely add them in here. So, this could be, if you're having a subrecipient implement a strategy and you're providing a training to those staff at that subrecipient, you might want to evaluate the subrecipient staff. And then I'm sure there are a plethora of other jurisdiction-specific levels that could potentially be evaluated depending on your strategies and interventions. And the takeaway for these evaluation levels is that you need to define what is appropriate for your jurisdiction, your EHE activities, and your system, because that's going to differ from jurisdiction to jurisdiction. So the next part of this planning tool is spelling out process measures and outcomes for each pillar of your EHE plan. And I'm going to review here what many of you are probably familiar with, so I'll just review this quickly. But process measures assess how well the strategies and interventions are being implemented and provide important information on the progress of EHE by providing feedback on whether your work plan is being implemented as intended, and can give insights into why outcomes were or were not achieved. So this might include measures such as like the number of services provided, the quality of the training for healthcare providers, or the extent of outreach activities. So short-term outcomes capture the more immediate effects of the interventions. So for example, this could include creating a new app for linking newly diagnosed folks into care. Intermediate outcome measures assess the more medium-term impacts of the interventions. So this could include improvements in linkage to care. And then the long-term outcome measures are the ultimate goals of EHE initiatives, including successful diagnosis, treatment, prevention, and response to EHE or to HIV. So the third key piece of this tool is developing evaluation questions. So this is a really critical piece of evaluation planning because it really forces you to think about what you and your stakeholders want to know from your EHE initiative. Evaluation questions are questions you develop to guide the focus of your monitoring and evaluation systems by specifying exactly what it is you want to learn from your program. They help you determine the scope, methodology, data collection, and data sources for your entire monitoring and evaluation systems. So it's really important to take some time to get input from all stakeholders if possible, including funders and participants or clients, and see what it is they want to know at the end of your program, because this is what will help you develop the most effective and useful monitoring and evaluation systems. We don't want to collect data for the sake of collecting data. We want to collect data that is going to help us answer these key evaluation questions. So taking that step back and saying, what is it we want to know, will help you create a focused monitoring and evaluation system that can be adapted as other questions are coming up throughout implementation. So you're not left at the end of EHE being unable to answer questions you're getting from a funder or other stakeholders, because you've already taken that time to think that through and make sure you're collecting the data necessary to answer that question. So now that we have gone over those three key steps of defining your evaluation levels, determining what your process measures and outcomes are, and developing evaluation questions, I'm going to run through an example with you all and give you an idea of how you might implement this. So in this example, you're an EHE coordinator at a state health department, and part of your EHE work plan under the prevent pillar, or actually this would not be under the prevent pillar, but this would be to increase linkage to high quality and culturally competent care among their priority population of young Black MSM. And some strategies to reach this goal include creating a mobile app for HIV positive patients to stay in contact with an HIV care linkage specialist, collaborating with CBOs to create a peer program for young Black MSM, and creating a statewide social media campaign geared towards young Black MSM. So I've gone ahead and filled out this table, and because this is exactly how this table looks in the EHE planning tool we'll be releasing. But ideally, this is something that should be filled out with a team, so different perspectives are taken into consideration. But I did just want to complete this table just to show you, give you some examples that you can also refer back to using these slides, and you know, give you some ideas, because I think although this is sort of how I think this table could be filled out. I think like there's argument to fill it out differently. So for instance, I had said that there's no other levels of evaluation were identified, but perhaps that there's a way that there's another level in your jurisdiction that you would like to evaluate. And that's totally plausible, totally feasible. But for the sake of this evaluation and for this example, and because it's just me filling it out, this is sort of how I filled it out. So again, this is meant to be sort of flexible and adaptable, and there's really no right or wrong answer here. Even what I put here is not necessarily the right way. It's just to give you sort of an example of what you could be, how you could fill this out. So on the right and the level of just, it helps you define what exactly the level is. So who we're talking about when we talk about the jurisdiction level, the jurisdiction staff level, subrecipient, and the priority population level. And then whether or not you will or will not be evaluating this. I think that, there's for jurisdiction staff level in this example, there could be the argument that you're not going to evaluate that level because you just don't have the capacity for it, or it's not an important part of your evaluation question. So again, totally adoptable, no right or wrong answer here. So in the next step, you're going to be writing out some of the process measures, your short-term outcome measures, and any intermediate or long-term outcome measures you anticipate seeing from your interventions. So with this example, we had an app being created, a social media campaign, and then some peer programs. So these are just, again, not an exhaustive list, but some ideas of what you could list out for process measures, short-term outcome measures, and intermediate and long-term measures. And again, those long-term outcome measures are typically going to be directly related to the EHE overall overarching goals for each of the pillars. So in this last step, I've again gone ahead and filled out with potential evaluation questions as they relate to each of the evaluation levels I've outlined in the previous slide. And so the one thing I'll say about evaluation questions is it's okay to be ambitious, but I think it's more important to be realistic and specific. And this is an example, so I didn't go too crazy since I also only have so much room on this slide, but I wanted to include at least a couple here just to give you an idea of like what are evaluation questions and what they look like. So I think one thing I will point out is that you'll notice I'm not evaluating every level for every strategy. And that's definitely a reality. I think that because that level may not really be pertinent to that strategy, and I also think there's a feasibility component and capacity component as well. So do you have the capacity to evaluate at every single level for every single strategy? I would probably guess not. But it's also, do you need or want to evaluate at the every level for every strategy? So I think it's important to determine where you want to invest your time and effort because you can sort of get lost in the sauce here. So I think it's important to be ambitious, but have sort of review for feasibility and realistic as well. And you'll also, with these evaluation questions, as you're coming up with them, you'll need to think about how you're going to be collecting data and setting up processes to be able to answer those questions that you or other stakeholders have about your work. So it's important to sort of think these through. So for example, at the jurisdiction level for the strategy of creating an app, what were the facilitators and barriers to creating the app? What processes or systems were changed at the jurisdiction to meaningfully incorporate the app into existing protocol? And then next at the jurisdiction staff level, to what extent were staff properly trained to utilize the app and engage patients? At the subrecipient level, to what extent were CBOs or providers utilizing the app as a linkage tool? And then at the client and priority population level, how many young Black MSM who utilized the app were virally suppressed within 6 months? How many young Black MSM who utilized the app were linked to care within 30 days? So just again, not exhaustive, but some examples for you of how you might fill out this table. So just some other considerations is that this document, again, isn't really meant to replace an exhaustive monitoring evaluation plan, but rather provide one way you can break down your evaluation. Evaluation is just one tool. That, like I said at the beginning, there's so much more I could go into this, but it's just should be one tool in your toolbox, and is not going to be the end all be all and answer every single question you have, but it should be a helpful one. As I mentioned, really the best practices around creating your monitoring and evaluation plan, you should be engaging a team of stakeholders, at the very least engaging a team internally, if not including HIV planning bodies, including your priority population, including funders if possible, because it really takes a variety of perspectives to create a comprehensive monitoring and evaluation plan. And then something that we talked about but didn't really totally get into is taking a step back to understand your system. I think now we all know how systems affect EHE and affect our work. But that varies from jurisdiction to jurisdiction. So taking that step back and looking at all the components that make up your system could be really helpful practice in developing your monitoring and evaluation plan. And I will hand it to Kaniqua to talk about what you can expect from the next webinar in the series.
Awesome. Thank you, Brittany. So I hope that you've taken a lot of what Brittany has outlined today and sort of started some forward thinking about how not only will you implement this kind of systems perspective into how you operationalize your EHE plan or even enhance it, but then start to think about what it actually means to put that into practice. So at the next webinar, what I'll be covering is an attempt to help you be able to answer some questions like the ones on the screen. So for instance, if you're thinking about this from a systems perspective, if you're thinking about this from the different levels of evaluation, then what sorts of questions, like Brittany mentioned before, identifying what those questions are is a really key component of defining how you're going to approach those different pillars and how you're going to incorporate that work into specific strategies. So once you've developed those strategies, what are some evaluation questions from those strategies that you want to be able to answer, and how do you choose the right data collection methods to help you answer those questions? And in addition to the data collection methods, where is the data? So knowing where the data is and whether or not you have access to it, whether or not your ability to access that data is something that's already part of your typical processes at your respective organization, or if that's something that needs to be developed and defined, is also something that we'll cover. We'll also ask questions like how you can actually identify if the methods of data collection that you're choosing to incorporate are relevant at any particular evaluation level. And then finally, just looking at how do I use that data to really be able to answer those questions. So like Brittany said, you don't want to collect data just for the sake of collecting data, because I'm pretty sure your time could be more better spent actually doing the work. So thinking about how not only are you going to collect that data, but then how to use that data to actually answer those evaluation questions. And beyond that, we're not just doing this to answer the evaluation questions. We're asking those questions, getting answers so that we can either improve or redirect or mobilize resources wherever they need to go. So those are just some things that we'll cover at the next webinar, really focusing on data tools and data sources and how to maximize those efforts as part of your evaluation plan. I think there's a next slide. Maybe there isn't. Yes, there is.
Yes.
Do you want to take this, Brittany? Yeah, I'll let you
yes.
take it.
One more Calvin and Hobbes comic. I just want to say thank you for taking the time out of your day to talk about systems and how you can use that systems thinking to more effectively monitor and evaluate your EHE initiatives. I hope you don't feel paralyzed with the knowledge like Calvin does in this comic. But I'm happy to take questions. You can put them in the chat. You are welcome to come off mute if you have a question. We have a few more minutes. So if anybody has any questions or oh, and here is the evaluation as well. So Kaniko dropped the link in the chat. You can also give us feedback or put your questions in that evaluation as well. We appreciate any feedback you can all give us. Because we can also, we want to make these as useful as possible for you all. So if you have any input on how to make this more applicable or something came up today that you're like, oh, I'd love to learn more about that, I think that could be really helpful. Definitely reach out to us directly, or you can fill out that evaluation and let us know as well. Yes, the slides will be available. I'm not sure when, but they will definitely be available. I think they'll be on Target HIV. Is that right, Kaniqua?
I will have to get back to you on that, but we will
Okay.
make them available. However, we have to do that, but yes.
Yes, I'm not 100% sure, but okay, Zoe said that we can send them out tomorrow. So they'll be definitely available in multiple ways. All right, folks. Last call for questions. I'm seeing a lot of thank yous. So I'm going to take that as a sign that there's no questions. Again, appreciate you all. Thank you for all the work that you're doing. And feel free to reach out to us with any questions that you have. Thanks all.